just to kind of finish up on rheumatoid arthritis drugs, other drugs are used. You do see patients put on low-dose prednisone orally, which is a steroid drug, and then occasionally you'll see where they're given intra-articular or in the joint space given steroid injections in an effort to kind of decrease inflammation, and also, immunosuppressive agents. And again, this is some of the same concerns in terms of risk factors that we already talked about earlier with glucocorticoids causing increased glucose levels in patients, which again makes people more at risk for infection. And then along with that, they're often on immunosuppressive agents, and so those together really make patients high risk for high glucose and high risk for infection. So monitoring them for blood CBCs, blood counts, and that kind of thing is very important, as well as having them being taught and aware of ways to prevent infection. These are some of the systemic complications that you see with these patients. So it's bad enough that they've got these joints that are being gradually destroyed, but they may have these exacerbations of flare-ups of the disease. They may have subcutaneous nodules. They can have respiratory complications, cardiac complications, some of which you'll see there. They can develop vasculitis of the skin. They can have periungual lesions, and you're saying, what in the heck is that? It's really kind of like a type of viral infection that's like having warts, and often that comes from the immunosuppressive meds they're on, and so then these viruses are able to take over and cause wart-like lesions on their skin. They may also complain of paresthesias, and then there's a few other more severe syndromes that they can go into. You may see very red, painful inflammation around the eye, both kind of on the outer version of the eye, and then a little deeper into the white area of the sclera. That really can cause some severe eye pain. They may develop inflammation of the lining of the lungs. They may develop pleural effusions, pericarditis, as well as anemia. So again, you're looking at their lab values for more than one reason related to anemia, and you're also looking at their overall body function, and respiratory and cardiac are two to kind of keep a close tab on in terms of your vital signs. So some non-pharmacological interventions, you can imagine that this is very devastating for patients as to having all this discomfort, lack of mobility, systemically feeling constantly fatigued. So you want to teach them, some self-management that deals with really getting adequate rest. Sometimes they may be wearing assistive devices for that particular joint that's not as functional because it really no longer be repaired. They may use different applications for ice or heat depending on what works for them in terms of discomfort. It's kind of uncommon for them to use plasmapheresis, and you might want to try to research that a little bit and determine why you think that is. It's real common for these patients to seek out complementary and alternative therapies. Lots of people take fish oil, for example, for rheumatoid arthritis, and it's seemingly somewhat effective. But things like that, you have to be really cognizant of a nurse when you're doing an assessment with somebody, like what kinds of medications or supplements might they be on that might really interfere with other medications and things, and you have to ask all those questions. Promotion of self-management, as much as they can do for their own self so that they don't become dependent, that helps them having better psychosocial and better feeling like they have control of the disease and take care of themselves. In terms of managing fatigue, they need to have not only adequate rest, but like take and do small activities and have frequent rest periods in between activities so that they do not overtire themselves. And then other things that might help them feel better about their body image, you kind of encourage them to do. And then they can, also have physical and occupational therapy to help them with mobility and learning new techniques to do things different ways. In terms of interdisciplinary care, key, if we're planning care, goals are going to be to reduce pain and inflammation, preserve the function as long as we can, prevent deformity if that's possible, really provide them with some psychosocial health supports. And then, like I mentioned, there's several different laboratory monitoring. Because of being on drugs like methotrexate, you're going to want to monitor their CBC, their liver transaminase levels, and serum creatinine because of the hepatotoxicity potential of those drugs, some of them, and then also that their kidney function is at a level where they can continue to take the medication. Next, a disease I want to talk about is systemic lupus erythematosus. And so you hear people constantly just call this lupus. But it kind of is a misnomer in the sense that, SLE should really include the systemic, because this really, while it's a inflammatory connective tissue disorder, it can really cause major body organs and systems to fail. It's kind of characterized by spontaneous remissions and exacerbations. It is really based on an autoimmune process where autoimmune complexes tend to be can also be attracted to the glomeruli in the kidneys, and so most patients will have some degree of kidney problems as a result of this disease over time. But again, it's an autoimmune process where they have kind of, a big flare, and then they kind of spontaneously go into remissions, and then they have a big exacerbation again. So it's on again, off again. Lupus only affects fewer than 25 people per 100,000, and that's over multiple countries here. Females are 3 times more likely to get this disease than males. African American women are 4 times more likely to develop than a Caucasian American, but when you look at Africans and Asians and African Caribbeans, or blacks in Africa, Asia, and the Caribbeans, it's not the same issue. So why that is, it's kind of unclear. But this is one of those things where you have a disparity of a disease in terms of the epidemiology, and the why is not truly known. The patho is chronic inflammatory, we've already mentioned. It's somewhat of an unknown etiology. Again, they think that immune complexes deposit into the tissues, causing this problem. And again, remission and flare-ups. This disease can have some specific triggers like pregnancy, exposure to sunlight. Another type of illness may make the lupus then flare up. Major surgeries can, silica dust, and then medication allergies. All of those type of reactions or stressors on the body can then make a flare-up occur of the lupus. So the psychosocial results can be devastating for this disease as well, because you never know really when you're going to have a flare-up. It limits a lot of your activities. You just really can't make a lot of plans in it, and you feel miserable during these flare-ups. So The American College of Rheumatology says that they have 11 criteria that would support a diagnosis of lupus, and 4 out of the 11 criteria have to be present to make a diagnosis. And so presence of these specific antibodies, ANAs, do not necessarily confirm diagnosis. So some people say, well, let's draw an ANA, but that doesn't necessarily confirm the diagnosis. There's more to it than that. So other lab tests that will confirm diagnosis is to get a skin biopsy, and we're going to see some conditions of their skin that on some pictures here soon. There are some other immunological based laboratory tests. When they do CBCs, often it shows pancytopenia, and it's really kind of because of the effect of the immune system fighting the system itself. And then you do see body system function issues that are like also related to some of this, is, in terms of checking different body, kidney function, liver function, other things to kind of see what might support the diagnosis. Clinical manifestations, they have a very telltale butterfly rash that you're going to see a picture of, polyarthritis, meaning symptoms of that in multiple locations. They can have osteonecrosis, where you have bone death, muscle atrophy, fever and fatigue. Again, renal involvement, like I already mentioned. They can also develop pleural effusions, pericarditis. They may have Raynaud's phenomenon that you'll see a picture of, as well as neurological manifestations and serositis. In your textbook, if you want to look at table 19.8, has even kind of more by system or body system, and so it kind of lays down maybe a few more than these even. This is the characteristic butterfly rash that you see with SLE. And then on the other picture there, you can kind of see how people's fingers will look when they have Raynaud's syndrome, and which is an odd presentation, so that's kind of indicates something's not quite right. In terms of treatment and complications, it's very key for them to avoid prolonged sun exposure. They suggest using a high SPF sunscreen. They may also wear clothing and things that has SPF embedded in it. You want to encourage them to have a well-balanced diet. Some patients will have to be on anti-malarial medications like Plaquenil. Severe complications, again, just to mention, renal failure can occur with this disease. They may develop premature heart disease. They may develop interstitial lung disease. Sometimes they're at high risk for hypercoagulation, stroke, again, necrosis of the joints, and then increased risk of infection and drug toxicities because of the renal involvement. And then drugs that are given for the skin lesions, they are usually prescribed cortisone drugs topically. Plaquenil also decreases the absorption of ultraviolet light by the skin, and so that's why the anti-malarial drug. Tylenol or NSAIDs, treating, again, joint and muscle pain and inflammation. They are usually going to be on chronic steroid therapy and immunosuppressant agents. And then there is one new drug that kind of decreases the response. It's one of the first approved drug in like 60 years for lupus, which is one of the MUMAB drugs. And again, the risk factors are very similar for these patients. Very high risk for infection. They're on steroid therapy, so they have the same kind of issues. And I won't read these to you, but I'll let you read through the fibromyalgia. It's sort of a related disease. The key issue that you're concerned with this is it really involves chronic pain, and the potential causes are multiple, and there's not a lot of data about that. But theoretically, it can be caused to some kind of dysfunction in the brain. And then these are just some of the symptoms that I'll let you read through. And then treatment really deals with these list of items here. And then I have you a couple little brief questions there at the end just to kind